And we're now recording.
Okay.
And now, because we're recording, everybody has fallen completely silent.
That's right.
Okay.
I see a friend, Joy.
Do we typically use the note taker? Should I move that person out? Or Sandra's note taker?
I think that's, isn't that a new Zoom feature where you can,
I would just leave it.
Okay.
Yeah.
All right.
But you can go ahead and get started.
All right. We'll turn over to Rocio.
Okay. Okay. Good afternoon, everyone. My name is Rocio Torres, and I am with the Overdose Data to Action States OD2AS at the Arizona Center for Rural Health. It is my pleasure to welcome everyone to our 2025 Arizona Center for Rural Health webinar series. Before I introduce our speaker, I want to share some housekeeping items with you. Please use the chat to enter your questions. Dr. Saira will address your questions throughout and at the end of her presentation. We will be recording this webinar and post the link on our website in the upcoming days. Visit the Arizona Center for Rural Health website for more information. The land acknowledgement of the University of Arizona is as follows. We respectfully acknowledge the University of Arizona is on land and territories of indigenous peoples. Today, Arizona is home to 22 federally recognized tribes, with Tucson being home to the O'odham and Yaqui. The university strives to build sustainable relationships with Native nations and indigenous communities through education, offerings, partnerships, and community service. Today, we have Dr. Saira Kalia presenting substance use in pregnancy, treatment approaches during pregnancy, and coordination of care. Dr. Saira is Associate Professor of Psychiatry at the University of Arizona and Director for the Arizona Perinatal Psychiatry Access Line and the Arizona Pediatric Psychiatry Access Line. Her contributions to the field of perinatal psychiatry include the Psychiatry Department's Perinatal Psychiatry Training Track and Clinical Service, and working to expand the department services in this area. Dr. Saira has served as Outpatient Medical Director and Associate Training Director. Dr. Saira provides national trainings for Postpartum Support International, PSI organization, and has made contributions to the national curriculum of reproductive psychiatry and the American Psychiatric Association's first textbook of women's reproductive mental health. She is a well-educator and leader, known for her patient-centered care and dedication to education. Welcome, Dr. Saira, and the floor is yours. I'm going to stop sharing now.
Awesome. Thank you so much for that very generous introduction. So I'm going to get started. For the audience, please feel free to put questions in the chat and I will try to monitor. I'm assuming you guys can see the screen. Is that, can I get a yes or no?
Yes.
Yes. Awesome. Thank you so much. So part of the goal today was kind of talk about substance use disorders. I'm going to be focusing a little bit more on opiate use disorders because in 45 minutes to cover all substance use disorders became a bigger challenge than I thought I could take on. So specifically, we're going to be talking about sort of the burden of substance use disorders, and then hone in on opiate use disorders and kind of focus on the guidelines of screening and treatment in opiate use disorders, specifically, obviously, in that pregnancy perinatal time period, and then go through that difference in pharmacological care. And hopefully I can make a case of why this is still sort of a discussion piece that we need to have about why we need this care as well. As I review this data, I'll be using heteronormative terms because heteronormative terms are what are honest to the data as well. So something to keep in mind. So let's just dive in. So as we think about substance use disorders, it's really important to think about, to keep in mind that the development and prognosis of substance use disorders is gendered, especially in the US. 45% of people aged 12 or older who use drugs are women. And women are also most at risk of substance use disorders between that age of 18 to 29 years of age, right? And so that obviously age group 18 to 29 coincides significantly with reproductive age years as well. In general, when you look at it, the most common use of substances that are used in pregnancy are like tobacco, alcohol, and cannabis. However, polysubstance use is also increasingly common. So 50% of women who use drugs during pregnancy will endorse that they're using more than one. So with that, let's talk about sort of how heavy it's getting in terms of the impact of these substance use disorders. So pregnancy-associated deaths due to overdose have more than doubled in the US between 2007 to 2016. When you look at data from the Pregnancy Risk Assessment Monitoring System, they have noted that 6.6% of these respondents are using a prescribed opiate during pregnancy, with 1 in 5 of those women reporting misuse and 3 in 5 saying they have been counseled about the risks of opiate use disorder. And then when you look at rates of, for example, maternal opiate use at delivery, rates of maternal opiate use at delivery have increased 4 times in the last decade. Other substances, other than, of course, opiate use, are contributing to an increase in perinatal substance use disorder in the US, like, for example, methamphetamine. Inpatient treatment for pregnant women for methamphetamine abuse has increased 3 times. When you look at marijuana use, the data says that marijuana use has doubled. In my personal experience, marijuana use is probably beyond doubled. And then there is something to be said about the fact that gender also likely modifies substance use disorder treatment and access and use. So when you look at historical data, we used to think that women were less likely than men. Women with substance use disorders were less likely than men with substance use disorder to enter treatment. More work has been done on that idea recently to kind of look at why that is. Why do women sort of enter treatment less? And so it's about, and the new work sort of highlights that there's inconsistencies in terms of access across groups. So there's inconsistencies with race and ethnicity considerations, and also there's barriers to treatment in terms of for women. So women tend to prefer all women care, all women substance use disorder groups, etc. Women have childcare responsibilities, they might have fear of child welfare reports, financial limitations, so it's not a simple thing in terms of like the fact that the treatment is available has to also be tailored to the patient population. So let's take a look more at sort of Arizona data. Before I kind of talk through this data, a few things we kind of need to keep in mind is what is pregnancy-associated death and what is a pregnancy-related death. A pregnancy-associated death is the death of a woman during pregnancy within that 1 year at the end of pregnancy, after the end of pregnancy, regardless of the cause. So if you died in pregnancy or 1 year after, regardless of the cause of that, that's a pregnancy-associated death. A pregnancy-related death is a condition that was directly, or a chain of events directly initiated by the pregnancy. So that is something to keep in mind. That's a big difference. So when you look on this box on the left side, this is January 2024, we got this data. This is Arizona Maternal Mortality Review Report data that looked at 2018, 2019 deaths in Arizona, maternal deaths in Arizona. So this is pre-COVID still. And this is the latest data set that we have. So in that data set, the most common primary underlying cause of death amongst pregnancy-related causes, chain of events initiated by pregnancy, was mental health conditions. And that kind of encapsulates substance use disorders as well. And we've seen an increase in both pregnancy-associated deaths and pregnancy-related mortality ratio. The other thing to keep in mind is 90% of these deaths in Arizona were considered preventable. So this is a huge, that's most of them we can assume are somehow related to mental illness, substance use disorders, and then of those, quite a significant majority are considered preventable, which is pretty sobering of a statistic. I don't have the 2018-2019 breakdown of which substances in Arizona were considered to be a challenge, but when you look at the 2016-2018 breakdown, the number one substance was associated with death were opiates. So it's a huge issue nationally, and of course a huge issue in Arizona as well in terms of getting these patients taken care of so we don't end up in limitations. some of the bigger things to keep in mind are state policies in terms of drugs and pregnancy. The policies in terms of drugs and pregnancy reporting have increased in the last 20 years. So there's 24 states and the District of Columbia, which consider substance use during pregnancy to be child abuse under child welfare statutes. 3 consider grounds for civil commitment. And these are important things to consider because when you think about the ideas of who's coming into treatment, what are their limitations, what's causing them to pause, all of these are considered, will come into play. And maybe some of the providers or people that are on the call have other people or take care of patients across the state lines. The other thing, 25 states and District of Columbia require healthcare professionals to report suspected prenatal drug use, and 8 states require them to test for prenatal drug exposure. And we'll talk about both those pieces in a little bit. So if you can keep that in mind, maybe there's a spoiler alert coming. In Arizona considers substance use during pregnancy child abuse, but it's not grounds for civil commitment. And so when drug use is diagnosed or suspected, Arizona requires reporting. The other thing to keep in mind with Arizona is one of the few states in which pregnant people are given priority access to general programs. So if you have a pregnant patient and they're like, I want to go into a TORP program, but I've tried before and it didn't work and they didn't let me in and there are barriers, it's a good thing to remind them that actually now that you're pregnant, you actually get priority access. If you weren't accepted before, you will definitely be accepted now. The other thing to keep in mind when Arizona, healthcare providers are asked to report opiate overdoses to the Department of Health Services in Arizona. But if you fail to report it, there's no legal penalties as of now. So that's something to keep in mind as well. I want to point out something else with regards to whether these policies work or not, because that's something to keep in mind. And the reason I'm bringing this up is because stigma and punitive policies can increase sort of overdose risk, if you will. So half the states that have adopted these policies, there's been additional research in terms of like, is there actually an increase in diagnosis or engagement or care? And so far, it doesn't look like it's making a huge difference in that regard. The other issue becomes with the policies is that policies are offsetting the responsibility of care from health systems which are designed for healthcare to surveillance systems of child welfare. And that's not exactly a health service provider, but that's neither here nor there. It's something to consider as you think about sort of stigma and how that can really weigh, especially when it comes to taking care of women and their reproductive time period or pregnant women in terms of taking care of that population, getting them engaged in care. Pregnancy in general is a good sort of window of time to kind of catch a patient, if you will. Women tend to endorse lower level of substance use during pregnancy compared to pre-pregnancy. And obviously that's a combination of advice from clinicians about the negative consequences of the drugs in pregnancy, negative messages about substance use from society, healthcare barriers, increased access to treatment, which in Arizona there is that case, and then some concerns about the impact of those substances. Those same forces of like those psychosocial forces of change, whether that's guilt or legal implications or concern for the baby, etc., all of that becomes significantly less pronounced after giving birth, right? So majority of women will resume substance use disorders postpartum. There was a study in 2015 that found that by 3 months postpartum, 58% of women had resumed smoking. I think it was like 41 had gone back to cannabis, 27% had resumed cocaine use just by 3 months postpartum. There was another article that was done in Massachusetts, and they found that overdose from opiates were heightened 7 to 12 months postpartum, sort of almost 4 times the risk in the 3rd trimester. So there is that sort of window of opportunity when it comes to pregnancy in which we can have this patient be engaged in care and kind of really help them commit to this treatment as well. And so, and again, that's where the Arizona policy is kind of helpful because they let you kind of engage the person into help. And so this is where we can help people come off of substances, and hopefully if we get this right setup of care in place, stay off of the substance as well. Let's talk a little bit about opiate use disorders. As I said, 5-fold increase in prevalence from 2000 to 2009. Maternal opiate use at delivery has increased over 4 times between that in the last decade or so as well. Psychiatric comorbidity is common, and I feel like that sentence doesn't do it justice, so I'm going to go into it a little bit more. Women who use substances during pregnancies have significant trauma histories, so including physical abuse and sexual abuse. And so when you look at sort of data with regards to just history of trauma and history of abuse, depending on the article you're looking at, the rates are anywhere from 55 to 99% in women who are seeking out care for substance use disorders. So highly comorbid with PTSD. Some of the data says PTSD is about 70% comorbid. So when I teach my psychiatry residents, I will tell them, if you find substance use disorder, go looking for PTSD. And if you find PTSD in a woman, go looking for substance use disorder, because they're so highly comorbid in terms of psychiatric conditions. This is also key because you can't just treat the substance use disorder. You also have to screen, diagnose, assess, and treat the psychiatric comorbidity, because they will play into each other in terms of maintaining somebody in compliance with either their, as I said, their substance use disorder or with their PTSD, depression, whatever it might be. So you kind of have to assess the whole person and make sure that you're treating all of their conditions at that point. Women with opioid use disorder will also use other substances. So 75 to 95% of them also smoke cigarettes. Important to know, because again, if you find something, you got to go looking for the other things. So you're coming up with a full treatment plan. 26.6 will report cocaine use, 56.6 will report regular alcohol use, and 73% will report regular cannabis use, which also informs treatment decisions. You're working to make sure that you're coming on to taking care of everything. There is huge racial and ethnic differences between when it comes to opioid use disorders amongst women, and also who gets treated, right? There is a crippling fear in the patients I take care of that their babies will be taken away from them if they come in for care. And some of the data says that fewer than 1 in 4 individuals with opioid use disorder will get any treatment in any given month of pregnancy. So we're looking at sort of a rise in the disease, and the treatment piece is not kind of keeping up. There's, of course, as I said, racial inequity. So the article on top is from May 2023, and it looked at 15,000 pregnant women with opioid use disorders, and they found that 31% of pregnant women received medication-assisted treatment at public funded facilities. So only 1/3 of them received it in pregnant funded facilities, but within that, pregnant white and Black women had sort of different rates than if you compare it to Hispanic women. The article on the bottom left, again, they kind of looked at inequity in terms of dose. So pregnant women with of color with opioid use disorder received 67% of the dose of methadone that white women received. So for example, white women in that study were getting a methadone dose of 145 milligrams, whereas Black non-Hispanic women were getting a dose of less than 100 milligrams. So so there's kind of those pieces in terms of stigma, provider education, patient concerns. All of those have to be kind of kept in mind as we're treating and assessing these patients and making sure that we're advocating throughout. The national standard and recommendations have not really changed. So the American College of Obstetrics and Gynecologists and the Substance Abuse and Mental Health Services Admission, SAMHSA, both strongly advocate for continuing opioid agonists such as methadone and buprenorphine throughout pregnancy. The clinical guidelines recommend that pregnant women in stable treatment should continue it throughout their pregnancy. So treatment is generally strongly recommended. Methadone, for example, we've had methadone since the 1970s. Methadone has been approved and recommended for use in pregnancy for patients with opioid use disorder since the 1970s. So this is not a new med by any stretch of the imagination. We've known about it, we've been taking care of it. And that also comes into that play of like, why aren't we further along? Why is it only 1 in 4 women who are getting treatment, or 1 in 3 women who are getting treatment for substance use disorders, especially when the recommendation repeatedly becomes using MOUDs, which is medications for opioid use disorders, along with, of course, the integrated system in which OBs, psychiatric providers, addiction medicine, social work, all of them are sort of collaborating together to kind of help this patient out and get into it. So we know what the gold standard is, we know what's recommended. So risk of untreated opioid use disorders. Actually, before I jump into risk of untreated opioid use disorders, let me just talk about risks in general of untreated substance use disorders, right? In general, women with substance use disorders are more likely to experience poor nutrition and inadequate prenatal care, chronic medical problems such as HIV, Hep C, and higher rates of intimate partner violence. There's, of course, things that are like medical complications of the drug use itself, which are things like bacteremia, cardiac disease, cellulitis, diabetes, sexually transmitted infections, like as I mentioned, and urinary tract deficiencies. And of course, vitamin deficiencies also are pretty common because, again, prenatal care, diet, all of that kind of tends into play. And then the other piece we have to keep in mind is when you're thinking about alcohol and drugs, they impair absorption of your micronutrients, which can lead to fetal abnormalities and intrauterine growth retardation, fetal alcohol syndrome, all of that. So that's like general substance use disorder risks in terms of untreated, but specifically let's talk about opiate use disorders. So opiate use disorders, the opiate itself is not directly teratogenic. So if you're using the fentanyl or whatever you're using, that's not directly teratogenic. However, there are gestational impacts to that, right? So it's going to cause opiate use disorder, untreated, will cause preeclampsia, can cause intrauterine growth retardation restriction, placental insufficiency, as well as placental abruption, premature rupture of membranes, postpartum hemorrhage, low ApGAR scores, preterm labor, and fetal demise. It will also have neonatal impacts. The neonatal impacts of untreated opiate use disorder in pregnancy include lower postnatal growth deficiencies, microcephaly, neurobehavioral health problems, including neonatal abstinence syndrome and sudden infant death syndrome. And it gets pretty bad in terms of the general impact as well. So this is a 2023 article, and it looked at postpartum opioid-related mortality in publicly insured patients. And so individuals with opiate use disorder had a 6-fold higher incidence of all-cause postpartum death than all other individuals. So all-cause death, 6-fold higher in postpartum, publicly insured patients with opiate use disorder. And there is a heightened vulnerability of these postpartum women with OUDs to preventable deaths, such as, non-opioid substances related to injuries and suicides. And so it's really important to kind of think about comprehensive care that's looking at mental health as well as substance health during that postpartum time period, because these are diseases that are fatal. Sorry, I jumped ahead a little too far. So let's say we've made the case, we need to take care of these patients, we need to identify them, screen, treat, all of that. All clinical care will begin with an assessment. And I want to make sure that people are thinking about the difference between screening and testing. Screening is when you're asking patients a series of questions or using a validated tool, and testing is biological testing. This is your blood, your hair, your sweat, your urine, whatever. So in terms of testing, and I'm not going to, in terms of testing, there is presumptive testing versus definitive testing. So this is like point of care lab. And so they're using like ELISA assay or antibody technology. So kind of similar to, if you will, the rapid COVID tests, or, like a rapid COVID test, they're cheap and they give you a binary result, present or absent. The definitive testing is like gas, mass chromatography. They're costly, they take time, and the results are specific and quantified. Like it's like what and how much was used. And so kind of keep in mind that that's something to consider. And there's, of course, bias considerations when it comes to drug tests. Either we're not going to get into sort of the bias just within drug testing in itself, but let's talk about sort of the difference between the two in terms of universal screening versus testing. Universal screening with a validated tool is recommended by ACOG, American Society of Addiction Medicine, AP, SAMHSA, CDC. Everybody tends to say, please go ahead and screen, and the screening should be voluntary. When it comes to testing, which is these definitive biological tests, urine drug tests, they're not recommended. And specifically, it's a reminder they keep saying that's not an appropriate measure of addiction, right? Like a positive urine test does not equal addiction. And that's another sort of concept. Let's take a pause there. Substance use is not substance use disorder. So drinking alcohol is not alcoholism, right? So it's something to keep in mind that the addiction threshold is different. A use disorder is different than just using. And that's the other piece when you talk about binary testing, presumptive testing, that they can't really make that measure. And sometimes we say, oh, you're in drug screen or something was positive, therefore they're an addict. So something to keep in mind. So they're not recommended by the leading sort of organizations. And they do say that you can do definitive testing when results of testing will inform decisions with major clinical or non-clinical implications. So you can, but you have to get the patient's consent. So you can't like test them without their consent. So screening questions, what do we do? Screening questions wise, there's quite a few validated perinatal substance use screening questionnaires. I like the 4Ps plus, if you will, or the 5Ps, whichever one you want to call it. So the 5Ps is your peers, your parents, your partners, your past use, and your present use. So it's like a 4 to 6 question screener. It's looking at past and recent exposure to substances. The substance use risk profile is like 3 questions. It kind of classifies you into like low, medium, high risk. And then the TASE is like a 4-question exam as well. There's other screeners, such as the one that the National Institute of Drugs Abuse, the NIDA, has a quick screen that can be appropriate because the NIDA, for example, is validated in general medical settings. You can administer them yourself. You can do it remotely by a staff member. You have to keep in mind, most of these screeners are sensitive, but less specific because they're kind of asking general questions. So they'll identify, so they'll help. And that's what it is. Like a positive screen is not diagnostic, right? Like a positive screener does not equal diagnosis of X substance use. A positive screener says you need to further evaluate things like defining factors like time period, frequency, amount of use, severity of impairment, all of the things you'll need to ask to kind of get to the diagnosis and then go. There was actually a study that looked at patient perceptions of they compared like 3 different tools, and they're like, who likes what tools? And so they looked at almost like 500 women in Baltimore from in 2017, 2018. And a lot of participants, and the reason I'm bringing it up is a lot of participants, like 40% of them, said they preferred the 4Ps plus because they felt that the 4Ps plus was comprehensive and concise. And that's also another reason why I tend to kind of partially be more favorable towards the 4Ps plus, but take that with a grain of salt, of course. That article, which kind of looked at perceptions, patient perception of the 3 tools, also suggested that when screening is confidential and includes sort of questions about a patient's background, pregnant patients more likely to answer honestly. So that non-judgmental kind of giving the test is also goes a little farther. So as I said, drug testing is not recommended, not an appropriate measure of addiction. Positive drug test is, and I'm quoting this because they were very severe about like this in all the guidelines, like isn't a positive drug test is not a sign of health or ill health. It's not not evidence of harm, and it's not a criteria for discharge. So these are just literally copy pasted from the ASAM and ACOG guidelines. And of course, consent is required. The other reason that I have this article up there is because fentanyl in labor epidural impacts the result of intrapartum and postpartum maternal and neonatal tox screens, right? So when it comes to testing, there's additional factors like false positives, true positives, potential for misinterpretation. And, if you're using opioids and epidural analgesia, they can show up in maternal and neonatal testing. So you have to take the full, as I said, picture into account. So as I said, screen, diagnose, treat. We talked about screening. Screening turned out positive. Then we're going to ask a lot more further questions, diagnose the person. Say we've diagnosed the person. Let's think about now we're going into treatment. In terms of treatment, I'm going to focusing a little bit more heavily on the medication piece of it, because that is part of where we're not seeing enough use of medication-assisted treatment. However, collaborative care is gold. Co-located care is great. Collaborative care is the gold standard of treatment, which the idea is that everybody that's taking care of this patient is under the same roof or can kind of communicate seamlessly with each other. So that's the person who's taking care of their addiction, the person who's taking care of their mental health, their OB, their primary care provider, their caseworker, their therapist. Everybody is together and kind of collaborating so that we can take care of all the pieces of this person's health, because again, it becomes kind of limiting if the patient does not have all of that together, and that becomes challenging. So in terms of treatment options, by treatment options, I mean medication treatment options. First thing you'll do is kind of acute detox, and then there's your buprenorphine products, methadone, and naltrexone and Vivitrol. We'll kind of talk about all of these in one at a time. Medication use for opiate use disorders, or MOUD. For pregnant women and with opiate use disorders, a opioid agonist pharmacotherapy is the recommended therapy. It is preferable to withdrawal because withdrawal alone is associated with high relapse rates. And so there are superior outcomes associated with medication-assisted treatment compared with withdrawal. So there have been repeated statements from all the leading agencies to kind of push the idea that medication-assisted treatment really does work. And what medications really do is they're stabilizing your intrauterine environment as well, right? They're allowing that fetus to develop normally, and that pharmacological stability, because you're not like on something and withdrawing it. That flux is not there, and that pharmacological stability is setting you up for recovery. And we also know, of course, that medication-assisted patients who get medication-assisted treatment are more likely to get prenatal care and sort of like general health as well. So when you think about benefits of medication-assisted treatments, there is decrease in infectious disease such as HIV, hepatitis B, hepatitis C, better engagement in prenatal care, and 70% reduction in overdose-related deaths for these moms. With regards to fetal benefits, reduction in fetal demise and reduction in intrauterine growth retardation, decrease in preterm delivery, and that reduction in fetal stress. And that, as I said, that fetal stress reduction is kind of byproduct of sort of reducing the maternal fluctuations, the fluctuations of maternal opioid levels. So you're kind of stabilizing things for the baby. This slide is from a colleague of mine, Dr. Ryan, who kindly let me state, because she'd just done a way better job than I could have done from scratch. And so with regards to opioid detox, inpatient admission is recommended for those with acute medical illness, significant polysubstance use, long-acting opioids, and if they're over that 23-week mark. If you're under 23, you don't really have any complicating factors, you have experience with like buprenorphine maybe in the past, you could kind of be detoxed, if you will, outpatient. That standard is not hugely different than what you do for like a non-pregnant patient, but the goal is, again, controlling the symptoms, induction with safety, and then while you're doing an induction, whichever one you're choosing, you would monitor them with the cows. And then, of course, when you're doing that, you're also monitoring for other symptoms of withdrawal, like pain and cramps and insomnia and restlessness and the sort of that itchy irritability and all of that. So you're taking care again of all the symptoms, and not just like we're taking you off of the fentanyl that you're on, or putting you on methadone or buprenorphine, and that's great. You need to take care of the whole piece of it. But most of the people that are doing inpatient detoxes are pretty good about all of that. So before we jump into medication-assisted treatment like methadone versus buprenorphine, let's talk a little bit about what pregnancy will do in general. Pregnancy is an evolutionary system that is designed to frustrate us who are medicating people, because the way that the body responds, normal human changes in pregnancy are like your liver enzymes are going to rev up and they're going to try to just get rid of anything that it perceives as a toxin, which are both medications and, of course, toxins. So as pregnancy hormones increase, so does your metabolism, and this is a system kind of designed to protect the fetus. So things like transcription of 2D6 enzymes, all of those will kind of go up. Your plasma volume, maternal plasma volume is going up. Your glomerular filtration rate is going up. So your kidneys are clearing things faster. The kind of ratio of lean muscle to adipose tissue is changing. So things that are lipophilic versus not. So there's a huge amount of pharmacokinetic considerations when it comes to pregnancy. And that's something that I'll talk about later when we talk about sort of considerations for dosing. I understand that I have 15 minutes left, so I might have to speed up just a tad. So when it comes to selecting an option, you got your methadone versus your buprenorphine. Those are kind of your two things. As I said, methadone. And of course, this is also with counseling, behavioral therapy in place, using motivational interviewing. Just because I'm focusing on medication-assisted treatments and the meds itself does not mean I'm by any way dismissing the importance of the rest of the treatment algorithm. So all of that has to be in place. Methadone, for example, has been in the standard for heroin addiction in pregnancy, as I said, since the 1970s. Buprenorphine came on the scene in the early 2000s. Methadone, average dose is about 60 to 120. Buprenorphine is about 16 milligrams. Just for reference, 60 of methadone is about 24 of buprenorphine. So if you're like, so 60 is not 16, 60 is 24. So methadone treatment, for those of you that might not know, it's part of like sort of like opiate treatment programs. You have to go there every day to pick it up and kind of take it and then go. So it's geographically limiting. You have to go, you need your transport. And people tend to think it's better for people with higher level of substances. There's improved treatment retention with methadone. And I think part of that social piece of methadone is something to consider. You're going somewhere every single day to pick up your med. You get to know the people. People are like, hey, how are you doing? You know, there's a social aspect to it as well that can be helpful. And people, did you go to your doctor? What did the doctor say? Hey, you know, like it's just humans are social creatures. Sometimes it's nice to have that community piece of it. Suboxone or buprenorphine, generally we tend to say lower levels of substance, but you kind of, and I'll come back to challenge myself on that in a little bit. It can be office-based. It's not always daily dosing, so you can do twice a day with it if needed. Transport is not necessary. There's increasing availability with many rural areas who don't have providers. We can do telehealth with it. That might be the best option if you're doing, if you have patients with concurrent benzo use or methadone overdose history, etc., and possibly has decreased now severity. So the mother trial is something that no talk on substance use disorders or opiate use disorders can actually be done without, I think you have to, it's required by law or something. it was a randomized double-controlled trial. There's multiple arms of it, actually. And it compared methadone-exposed infants to buprenorphine-exposed infants. And in comparison, buprenorphine-exposed infants tended to require less morphine to treat neonatal abstinence syndrome, less time in the hospital, had less time in the hospital being medicated also. NAS rates did not differ, but the impact of the addiction sort of on baby was different. However, women on buprenorphine were twice as likely to discontinue treatment and more likely to use other treatments. There will be, in my opinion, a lot of talks that will say, these are the advantages of methadone, and this is the advantage of buprenorphine, and this is that, and this is that. And I will always come back to the most effective treatment is the one the practicing person is willing to engage in. So if the patient says, hey, this versus that, that is a big deal to me, because you want that person engaged in treatment and you're building that rapport and whatever works for them. And sometimes they know their addiction way better than I do. So my preference tends to kind of be swayed more by that factor than sort of any other factors about engagement in treatment and long-term consequences and all of those things. And I know that that's not generally how people do it, but that is still my bias, because engagement in treatment and kind of retaining them in treatment is so key, especially when you think about the amount of patients, you know, that 6-fold increase in postpartum opiate use disorder deaths. Like that's a huge amount of loss. So anything that they are going to engage in, I also feel like they'll stay in. Now, coming back to pregnancy being an evolutionary system designed to frustrate me, the reason why it's frustrating is because of the change in metabolism and that flux of it, there is a huge amount of shifting in terms of what the half-life of methadone is. Some patients are ultra rapid metabolizers, some ultra slow metabolizers. And so most non-pregnant patients will do fine with once a daily dose, like only and by most, I mean like 70 to 75% of non-pregnant patients are fine with that once a daily doses. But even within non-pregnant patients, you'll have people with difference in metabolic, in sort of their metabolic systems and their metabolism. What we're doing essentially when it comes to medications like methadone in pregnancy, we're dosing pharmacokinetically blind. I don't know what your metabolism is like. We have to kind of say we all assume all of you are the same. We know in pregnancy that metabolism is going to rev up. So that patient is going to need either a higher dose to kind of keep you at the same dose, same serum level, if you will, because you're just chewing the drug up faster for lack of a more scientific statement. Or you might need to split the dosing. You might be running out of it faster. So these are patients who, when they're in their second trimester, third trimester, they'll start saying things like, I'm having more withdrawal symptoms, I'm having cravings in the evening, what's wrong with me? And they tend to turn inwards in terms of shame and regret and sort of like, what is wrong with me? I'm such an awful person kind of thing. And these are questions that we as providers need to ask and to be check in on, because we know that their metabolism is revving up as they get more and more pregnant. And so that drug level, serum level is dropping. So they might not know this, but that's something that we have to keep in mind. And then this becomes a challenge with methadone because, again, this is a once daily dosing. That's sort of the federal regulation. And dosing flexibility becomes a little bit of a challenge, if you will. Split dosing might be ideal, and you can make the case for that, but that becomes, again, as I said, challenging in terms of the regulations as well. When it comes to MOUD levels in later pregnancy, you are finding that your serum levels of methadone increase liver activity, increase volume of all of those things. So approximately around 28 weeks, you might need to have a 10 to 20% increase in that methadone level just to keep it at the same serum level. Again, we would fix that postpartum. So when you're about 4 to 6 weeks postpartum, because your estrogen levels kind of climb up to 300% by 36 weeks, and they crash back down to pre-pregnancy levels by 4 to 6 weeks. So you're bringing the dose back down because all you are doing was making sure that you're maintaining the same serum level. Anything that is too low dose with regards to buprenorphine, you likely have to adjust that as well and kind of do the same thing that we do with methadone, which is adjust during pregnancy and kind of bring back down. Let's talk a little bit about buprenorphine as well. Buprenorphine, as I said, came on the scene in the 2000s. It's a sublingual pill, at least usually was. And now in the last few years, we have two other sort of options, right? In buprenorphine. So there's the Brixadi and the Sublocade. So these are extended release options. So extended release, Sublocade is a monthly extended release option for buprenorphine that you can kind of take a monthly injection. The problem with that is while buprenorphine is considered safe in pregnancy, extended release buprenorphine has NMP. I'm going to try to say the name. I think it's N-methyl-2. I'm getting recorded. I'm not even going to try to say the name. NMP is part of the extended release buprenorphine, and that part in rats is found to be teratogenic. And so that is where we kind of have a consideration of like, can we do the NMP, the Sublocade, which is a monthly ER, monthly extended release buprenorphine shot in pregnancy. Most of the case studies we have, which is sort of some of the lower level of data that you can get, say that the use in pregnancy has been fine. There hasn't been any adverse effects of it, but we have minimal data that is human data. And the animal data is not the greatest, because in animal data, they gave them NMP at equivalent days doses, and they had pre-implantation losses and delayed ossification and reduced fetal body weight. And so sort of the idea would be the general recommendation is shared decision-making around the use of Sublocade extended release, because you're working with the patient to see what are you comfortable, what risk are you comfortable taking, what risk am I comfortable prescribing. I will tell you, Sublocade will not be my first choice in pregnancy, but again, it's a case-by-case thing, depending on the case, depending on the patient and what the patient is accepting, because again, I'm not the one that's pregnant, they are, so they need to be on board with it. The other formulation is Brixadi, and Brixadi is the weekly formulation. This does not have NMP. So Brixadi has a weekly and a monthly formulation. The weekly formulation does not have NMP. The monthly, of course, does. And so there's an ongoing study with regards to moms using sort of Brixadi, the weekly formulation. So it seems like that could be potentially a great option. While in the US, Brixadi only came out in 2020, it's been around in Europe for a while. So we have a few more sort of data sets there in terms of Brixadi. There was actually a pragmatic RTC that's the screenshot from. So that could be another option if you need something like a weekly maintenance, weekly option for patients for extended release. The other thing that's a huge thing to think about is pain. All of us have heard this. Labor is the most painful thing you'll go through in your entire life. Obviously, not an exciting thing to look forward to. I don't want to look forward to the most amount of pain I've had in my life. Then you add into the fact that I have a history of opioid use disorder, and I'm paranoid. Personally, I'm worried about maybe what that treatment is going to look like for pain control. And then also I'm worried about, will they treat me adequately? So I think one of the few things to keep in mind, reassure the patient that your pain will be managed. Delivery is obviously painful, and that you can achieve effective analgesia. And in patients who are on MAT, on methadone and buprenorphine, you should continue that without dose change throughout labor and delivery. There's other things that you can consider in terms of alternative treatments for pain, like you can do regional anesthesia if possible. And then if you are adding opiates onto that, so if you're doing, morphine or whatever else you're doing, you can individualize the dosing. So I think the main takeaway would be for patients who have MAT on board, like methadone or Suboxone, there's no difference in perioperative opiate requirements, right? So it's not like, oh, you're taking methadone, so you need less or something like that. So that's generally something to consider in terms of pain management. And that's something that I try to address with patients sooner rather than later, because I don't want somebody living with the dread of what's going to happen to me and am I going to live in pain. So something to keep in mind. Naltrexone. So the mainstay of opioid use disorder treatment is methadone, buprenorphine, medication-assisted treatment. Naltrexone is a non-selective opiate receptor antagonist. So in therapeutic doses, it block the euphoric effects of opiates, right? Which is also methadone and buprenorphine are also opiate agonist drugs. So we've got naltrexone data in non-pregnant patients that it helps with efforts to maintain abstinence. There's an injectable form as well. Naltrexone will cross the placenta. And anytime I say that, I have to do the caveat of, with the caveat that pretty much everything crosses the placenta. It's about sort of degrees, if you will. So because the other thing to keep in mind is naltrexone kind of clears maternal circulation pretty quickly, and I should probably add that to the slides. And so it'll clear out of your system pretty quickly, and that's another reason why we have the injectable formulation. and you need to tell moms that, and you need to tell patients that, because as it clears out quickly, relapse could be a consideration, because it kind of helps with that idea of cravings as well. But the drug tends to be well tolerated by moms, by the mother and the fetus. Newborn infants don't really experience neonatal abstinence syndrome if it's an naltrexone medication-assisted treatment is maintained. So you could try naltrexone. The newer data, the data isn't as robust as it is, for example, with methadone. However, the early data seems to be pretty positive. So it does help with continuation of treatment or risk of relapse. There's a risk of relapse with discontinuation. All right, I'm not going to get too much into intrapartum pain management, because I also know we're running low on times. Neonatal opiate withdrawal syndrome. This is a risk for all opiate exposed babies, right? This is all opiate exposed babies are going to have this risk of opiate withdrawal syndrome. It's independent of the dose of opiate as well. So it's regardless of how severe your baby's at risk of it. And in essence, it's a dysfunction of the autonomic nervous system, your GI tract, and your respiratory system. So it'll show up in about 30 to 80% of infants who are exposed to opiates. Your peak symptoms will be 72 to 96 hours. This one will always haunt me because there's this case that is stuck in my head around it, because that patient was very reassured the baby didn't have any symptoms right away, and then the baby showed symptoms a day or two later. And I feel like I could have warned her and kind of avoided the distress she had, or at least mitigated it to some degree. So again, symptoms will peak 72 to 96 hours after birth. So my baby might show a difference in response a little later. And there are evidence-based treatments for it, right? You monitor the baby, eat, sleep, console. And so the non-pharmacological treatment for NOWS is a big deal, which is your quiet, dimly lit room. You handle the baby gently, you swaddle, you pacify, you rock, you room in with the mom. Rooming in tends to kind of have a reduction in NAPS length and stay and cost, because it encourages sort of that skin to skin, quiet environment. There's actually some data with regards to non-insertive acupuncture with babies. So that could be good. And then breastfeeding is recommended in terms of helping babies with NOWS and kind of encouraging that mother to be a mother and kind of enjoying that maternal fetal piece. The last few things that I'm going to talk about is contraception. I'm sorry, I can't not talk about contraception. That's a problem. Postpartum patients in general are less likely to use contraception, 50% compared to 81% in the general population. And the type of contraception they use kind of varies, right? In terms of most people will use condoms, which we know have a higher failure rate. Part of the barriers are they're not aware of options. They have a history of intimate partner violence or prior sexual trauma, or there's stigma, etc. My preference is the discussion about contraceptive options should begin prior to delivery, and that's why the integrated services are so helpful. That there was an article that looked at past histories of sexual abuse and trauma, and kind of how the patients who had those histories were more reluctant to think about contraception and using barrier methods or anything that was getting inserted into them, which makes sense when you think about it. So that's also another reason to kind of bring the conversation up earlier, so we can have that conversation and that decision kind of made. Because again, there's a sharp drop off in the postpartum follow-up for moms with opiate use disorder. So as I said, breastfeeding. Encourage breastfeeding when patients are on medications, decreases the severity of NOWS. And then in general, the American Academy of Breastfeeding Medicine, Academy of Pediatrics, College of OBGYN, SAMHSA, ASAM, all recommend breastfeeding for women with substance use disorders who are in treatment programs or have had negative drug screens, if you will, and allow the person to breastfeed if they're willing to or desire to. And then a few things that will help you retain your patient in treatment, because people will engage, as I said, during the pregnancy time period, but postpartum, there's a drop off. And at 3 months postpartum, a huge amount of people start to withdraw. A few things that will help people stay in treatment is access to early treatment, aggressive opioid withdrawal, and then antidepressant prescribed in the 3rd trimester, regardless of whether there was a diagnosis of depression, anxiety, PTSD, whatever. Antidepressant prescription allowed for higher retention in treatment, breastfeeding, and lower sedative use in the 3rd trimester, as well as providers that are available and comfortable with long-term treatment and care. 56% of patients discontinue MOUD at 6 months postpartum. So that's something else to keep in mind also. Peripartum depression, 9% of people will have, I'm not going to go into depression in much length. However, I would say there's a significant amount of comorbid depression, anxiety, and PTSD. Diagnose it and treat it, because regardless of the disease process, whether it's opioid use disorder, cardiac illness, hypertensive illness, if you treat the depression, their compliance into the rest of their healthcare increases. And we've seen that again and again, regardless of the disease. And does it work? Does opiate treatment actually work? There's not a lot of long-term longitudinal studies. So there's a few longitudinal studies that are looking at sort of what happened to the patients who were in opiate maintenance treatment. This is June 2020. They followed 67 moms who used opiate maintenance treatment during pregnancy like 10 years ago. And they found 10 years later, there was lower mortality in the moms who were in the opiate maintenance treatment. 80% of moms had parental responsibility, so they were parenting. They had low use of legal and illegal drugs, and 80% sort of retention in the opiate maintenance treatment program. So majority of women were doing well 10 years postpartum, which I find a very heartwarming study to kind of go back to. Okay, they do well. So check the stigma at the door. Use validated tools to screen for the whole system, like social biological conditions, and then kind of check in with your colleagues to kind of think about what's going on. Promote early use of medication assisted treatment or medications for opioid use disorder, and kind of think about anything that'll help them stay in treatment: early treatment, aggressive treatment, breastfeeding, mental health treatment, longitudinal chronic disease management. If you are a provider and you're like, oh my God, that gave me a lot of information, but I have more questions than I have information, then you can find a lot of education with NGH, ASAM, ACOG. There's a lot of education out there. If you're worried, you can also call us at APAL. We are the Arizona Perinatal Psychiatry Access Line. So if you have a case in Arizona, call us. We will give you free advice on how to handle it, and we pick up the phone, which is also nice. All right, so I'm going to pause here.